So I'm going to talk a little bit about the relevance and impact of novel agents in hemophilia care paradigms. So when we talk about the approaches to hemophilia therapy, this is a good schematic to kind of think about factor level and hemostasis and treatment burden. So you can see that with factor or the standard half-life factor, more frequent treatments, more peaks and troughs in the hemostatic and non-hemostatic level. Extended life factor products, maybe a little bit longer, but still the peaks and troughs. Non-factor therapy, maybe not getting your thrombin generating potential as high as you do with a factor therapy, but it's consistent. So with these rebalancing agents or mimate or emicizumab for hemophilia A, you may have some just persistent baseline thrombin generation. And then we go into gene therapy where there's a wide treatment window of knowing what the actual level will be, potentially could be thought of as a cure. For some patients that may be true, but for some it may not be true. But that would be the goal, and then to ultimately lead to where no further therapeutic prophylaxis is needed in that regard. So when thinking about making treatment decisions for your patients, some of the strengths and weaknesses, the standard half-life factor, great data, many decades of experience, very safe. Even the plasma-derived products today, there's been no viral or otherwise infections that have gotten into the supply since around 1992, so it's very safe. But the weaknesses is obviously frequent infusions, inhibitor development, their intravenous access. As I mentioned, the extended half-life concentrates, still intravenous, you may be able to get higher sustained factor levels, maybe for those patients that are more active, that could be better sometimes or preferred compared to some of these rebalancing agents. But again, still the inhibitor development and they're intravenous. Then we talk about all these non-replacement therapies or rebalancing agents, some that Dr. Simpson mentioned and others that are on the market, they're subcutaneous. There can be variable injections. Some are daily, some are weekly, some can be every few weeks or even monthly or beyond that. But the kind of one of the weaknesses can be that though they do provide some consistent thrombin generation or bleed prevention, it may not be quite as high as we need for certain activity levels, and it may not be a quote unquote cure because the coagulation activity is not within the normal range. And also, as we manipulate the coagulation system, there is this potential for thrombosis, and even in a patient with a bleeding disorder, and we're learning how to mitigate those risks in that regard. With gene therapy, obviously a one and done treatment would be preferred to restore endogenous factor 8 or 9 production. But as Dr. Simpson mentioned, some of the pre-existing immunity against the adenovector, the immune response, the need for immunosuppression, the unknown durability of the transduction, the length of expression, really the lack of long-term safety. I mean, we're getting towards 8-10 years in some of these early patients that were on the trials, but not knowing in the real world data it will be ever evolving because we are just now able to use this in the clinics. And then also patients with inhibitors they're not right now able to use gene therapy in that regard. As then we're going to talk about what are the evolving treatment goals in hemophilia? Is it time to change our treatment goals? So early on, especially in the the 1940 to 70 range, I mean, we were just trying to keep alive with hemophilia. And then as we have moved into this ever evolving treatment landscape, thinking of quality of life, normalizing hemostasis, dealing with some of the other holistic things in a person's life like anxiety, depression, mental health, having a normal life expectancy, and really what are the treatment options and the treatment goals? Can we allow patients to do pretty much everything that someone without a bleeding disorder does? These is kind of the moving target. Historically, when we just had factor concentrates, the goal was keep people above 1% because we know severe hemophilia A and B is less than 1%. Now we know that people will bleed maybe even at 5%, maybe at 10%. How high do we need to get the hemostatic level? And that can differ for different people based on their activity levels in that regard. So some of the key advantages to the rebalancing agents in particular, you can target the broader coagulation cascade rather than a specific clotting factor. Could be potentially used in patients with inhibitors, right? So if you have an antibody to factor 8 or 9, you have this differing mechanism to restore hemostasis. You can have less frequent injections, and you can significantly reduce the frequency of bleeding episodes, maybe with lesser treatment burden.